Good evening, ladies and gentlemen. Welcome to our webinar this evening. This is the Nikon-Optos imaging webinar. Today, we're very pleased to have three speakers, and our theme and topic of today's webinar will be on the management of retinopathy of prematurity and pediatric fundus diseases. Today, I have accompanying myself. I'm Dr. Gavin Tan from Singapore National Eye Center. I have Dr. Zhang Guoming from the Shenzhen Eye Hospital. He's an esteemed retina specialist with a very strong interest in pediatric retinal disease, in particular setting up retinopathy of prematurity screening. And I also have with me Dr. Ding Xiao Yan from the Zhongshan Ophthalmic Center, who's another retina specialist with a keen interest in pediatric retinal diseases. So without further ado, I welcome everybody. I hope everybody's having a good day. And we'll go on to the first talk today. And the first talk today will be presented by Dr. Zhang Guoming. And his topic will be on the approach to pediatric retinal diseases and retinopathy of prematurity, in particular, screening, treatment, and follow-up of babies with ROP. Dr. Zhang?
Dear Chairman and colleagues, it's my pleasure to report treatment and prevention of ROP in Shenzhen, China, from 2003 to 2020. I'm Zhang Guoming from Shenzhen Eye Hospital. I will report ROP project overview, influence, case reports, and acknowledgement. Part 1. ROP is a vascular proliferative blindness causing ocular disease. It's a learning cause of childhood in the world, but timely screening and early treatment can avoid blindness. Approximately 100,000 children with ROP have been diagnosed worldwide each year. ROP has risk of high myopia and refractive error and heavy facial burden. But early screening, early detection, and early intervention for neonatal eye disease has gradually become a consensus among ophthalmologists and pediatricians. Vision 2020, global initiative for the elimination of avoidable blindness, the right to sight. Here is the epidemiology of ROP in China. China has a population about 1,400 million, and there are 12 million newborns 1 year, and there are 1.2 million prematurities, new babies 1 year, and there are about 120,000 ROP cases 1 year. In Shenzhen, the city has a 10 million population, and there are 200,000 newborns 1 year, and there are prematurity new babies about 10,000 1 year. There are ROP cases about 1,500 1 year. Part 2. Here is from 2,203, we establishment Shenzhen ROP screening cooperative group to screening and treat ROP case. By now, we have 33 hospitals in the cooperative group of Shenzhen. We have Science and Technology Project of Shenzhen, Newborn Blindness Prevention and Treatment System Construction. In this project, treatment required ROP in Shenzhen 100% timely intervention treatment, and that's 0 case for 19 years about late stage of ROP. We have International Cooperation Project of Shenzhen. It's a study of myopia status and pathogenesis in children born prematurely. By 2022, we screened 40,000 cases and 2,000 cases underwent cryotherapy or photocoagulation or anti-VEGF injection. We also establishment Shenzhen ROP screening cooperative. It's a cross-provincial and municipal screening network has been established. Remote diagnosis, appointment, and query information. We built an integrated fast treatment channel for screening and treatment, ensure full coverage of ROP screening in Shenzhen and its surrounding areas. The social welfare benefits we funded by Disabled Person Federation and the Civil Affairs Bureau of Shenzhen. There are 287 children have been treated with emergency surgery, and 200 children have been saved from blindness. The amount of funding has reached 2.32 million renminbi. The talent cultivation. We invited to attend special academic lectures on pediatric retinal disease at home or abroad for 48 times. We organized 230 academic exchanges, including medical care, scientific research, teaching, and training. Here is achievement exhibition. There are 104 papers have been published in SCI or Chinese code journals. There are 6 books about ROP published, about 29 core grants and 2 national grants. There are 7 patents. Part 3. The research, including explore pathways and intervene the pathogenesis of ROP. We carried out AI-assisted prediction of various pediatric blinding retinal disease use deep learning. Also, we carry on metabolomics and genomics for screening by biomarkers of ROP. Experimental intervention studies find new treatment pathway. We performed new technologies in pediatric retinal diseases, including minimally invasive vitreous surgery, intravitreal injection combined with laser and photocoagulation therapy. Also, we established a biospecimen bank dedicated to the pathogenesis research and improve the diagnosis of the disease comprehensively. Here is the impacts. We combined treatment experience cited by the American Academy of Ophthalmology consensus. The result of anti-VEGF treatment of ROP, cited by the coherent database of systematic reviews. Perioperative treatment outcomes, cited by guidelines for the treatment of premature infants with oxygen and retinopathy, revised 2013. Guidelines for screening ROP and photoimmunity eye disease, cited by a quality evaluation of Chinese ophthalmology clinical guidelines. Part 4. I will introduce two very important cases. Case 1. Here is my first ROP case received cryotherapy. Here is the name. Female. Birthed in 2003. Gestational age 26. Birth weight 0.75 kilograms. When arrived PMA 35 weeks. We diagnosed Zone 2 Stage 3 plus threshold ROP, and we performed cryotherapy for both eyes. We follow the case for 19 years. Here is the refractive status when she was 19 years old. There's high myopia and strabismus, but the choroid vision is good. It is very interesting. The lens cystic is abnormal, and Alex's lens is not very long, just 26. His visual field is about its normal. His anterior segment OCT, we can see there's a very shallow anterior chamber. Here's the slow for finders. The optic disc posterior segment is normal, but anterior segment is cryotherapy scars. is the corneal topography and biometers. When she was 16 years old, we can see the cornea is very steep. Is OCT and OCTA. The shape of fovea is flat, and the OCTA of macula is abnormal. Here's the second case. The case named Xu, female, born 2004, get Asian age 32, birth weight 1.3 kilogram, diagnosed zone 2 stage 3, and we performed cryotherapy. We can see the refractive status when she was 18 years old. It's strabismus, but the correct vision is good. The lens is big and the helix length is small. Here's the visual field, anterior segment OCT, a shallow anterior chamber. Here's the corneal tomography and biometrics. Also has a steeper cornea. Is the finders slow, showed normal optic disc and posterior segment, but anterior segment is cryotherapy scars. For this case, the OCT of fovea are normal, but the OCTA of macular is abnormal. Here's the VP and the ERG is normal. That's all. Finally, I will thanks my group. Thank you.
Hi, everybody. Welcome back. For those attending the webinar, there is a Q&A section where you can submit questions you would like to ask the panelists, and I can present that to the panelists. And during the presentation, they may also answer it directly. So thank you very much, Dr. Zhang Guoming, for that wonderful talk. And I think congratulations on that very impressive effort. I think talking about 40,000 babies screened a year is a pretty amazing number. And the thousands that you treat, I think you had 2,000 cases treated a year. I think in the whole of Singapore, we probably treat 20 cases a year, but we're a tiny little country. So just to understand a little bit more about the success that you had at this screening, when you expanded this program throughout the country, was it something that was easy to do? And I think what was the main thing that enabled you to have some success? And while Dr. Zhang gets ready to answer that question, we will also have a polling question for the audience. And the polling question is, what is the state of RP screening in your country? If you could give a polling answer so we can at least understand the conditions that our audience has, and we can bring that up for discussion as well. So while they're answering the question, Dr. Zhang, would you just like to mention one or two things of how you managed to set up this program initially? While we're waiting, Dr. Zhang, would you like to just tell us a little bit more about the screening program that you have? Is it something that's mainly driven by ophthalmologists examining with an indirect ophthalmoscope? or is it mostly imaging based where you have, for example, a contact picture taken for every ROP baby that's screened?
Okay, that's a very interesting screening. In my opinion, ROP is the meaning blindness disease in children, and ROP screening is popular in the world, mostly in developed countries. In China, maybe we covered number 3. Most cities and regions screen ROP by Chinese ROP screening guideline.
And you had a lot of success identifying disease. Is this mainly screening with an ophthalmoscope, or do you do, for example, contact imaging for every baby, like a RETCam imaging and something like that, in order to help you better identify plus disease?
In my hospital, we use RETCam or Chinese wide field digital camera combined with binocular ophthalmoscope to screen.
And I know your group has been developing some artificial intelligence solutions. Do you think in the future we are going to need this to help us better define when to treat and when not to treat? Or do you think just ophthalmoscopy is going to be sufficient?
Yes, because we in my group we began RP screening and comprehensive treatment from 2003. For these 20 years, we collected more than 40,000 premature babies for screening and treat 2,000 cases. So we have a group including more than 30 ICU. We collected 500,000 pictures. So we carried out several AI projects about ROP. That's all.
Good. We hope to hear more from that work in your future publications. So going on, we like to keep up with time. We have our next presenter, Dr. Ting Xiaoyan, and she'll be talking about ultra-wide field imaging and fluorescein fundus and geography in children with retinal diseases. Dr. Ting?
Hello, everyone. It is my great pleasure to be here to share with you my experience in using ultra-wide field fundoscopy and fundus fluorescence angiography in children with retinal disease. This is Xiaoyan Ding from Zhongshan Ophthalmic Center, Sun Yat-sen University. As you know, fundoscopy in adults is a very basic, easy, but immensely valuable tool to all of our retinal doctors. It is of great help to disease documentation, treatment monitoring, and patient education. I would like to say we stick with it in our daily practice in both outpatient and inpatient clinic. However, fundoscopy in children is still challenging, which is especially difficult to younger children who are unable to sit still, who are difficult to maintain the fixation. It is quite challenging even for experienced doctors and technicians. Looking back to the history, decades ago, we had cameras with 45 degree, which is now called as traditional fundoscopy. The quality of images is good with high resolution, but the extent is limited, only covers the posterior pole. Furthermore, the good imaging could be reached only if the child is very cooperative, can maintain an upright seated position. Later, we have RetCam wide-angle imaging system. I would like to call it the first breakthrough in pediatric retina. Here are two sample images. The left one is from a 1-year-old boy. It seems a little blurred here. Actually, this is a case of congenital retinoschisis. The retina is splitted, the inner retina just like a veil floating in the vitreous cavity. The right one is from a neonate girl. The retina cannot be seen as covered by the vitreous hemorrhage. Although the reason of vitreous hemorrhage is unknown, the clinical sign is well documented, which is very informative and objective for our clinical practice. RetCam brought us a new view, a wide view of 130 degrees. However, RetCam had some shortcomings. As you have already seen, the quality of imaging is relatively poor. Most importantly, it is a contact system for imaging acquisition. A lens should be applied directly on the ocular surface on the cornea. So, when we use RetCam, I understand this picture might make you uncomfortable. The small baby was crying. Her mom is holding the baby's head with her hands. Unsurprisingly, she was scared. She was heartbreaking so much. As to the technician, she was trying her best to concentrate, to snap as quickly as she can, at the same time to monitor the picture quality. Oh my God, all the parties are exhausted, not only the baby, but also the parents and the practitioner. So, RetCam can be only used in who are too small to resistant examination, or sometimes when the examination was performed under anesthesia. In fact, we have more complicated possible scenarios in which the RetCam is not suitable. So, here is a quick question for all of you. What is your most want in evaluating pediatric retinal disease? To me, the answer is one simple photo, which is fast, easy to use. It will be better if it is child-friendly. What means should be non-contact. It will be perfect if it is reliable, cost-effective. Now, Optos is the answer. Optos is not a horrible exam, but again, even in younger children. This is what Optos California is looking like. Here is a small observation hole. You know, the children are always curious. Everyone is curious enough to find the world in this hole. From this small hole, both the children and the doctors see a big world. The most valuable feature of Optos is ultra-wide field. When compared to the traditional camera, if we put the images together, we found more extent to peripheral and far peripheral retina. When compared with RetCam, it is much extended to the peripheral using Optos, showing not only the retina fold, but also the reason for fold, the anterior proliferative vitreoretinopathy, which is shown as red star here. Why? Because the underlying mechanism, the light source, the color, and are totally different. Another advantage is Optos is mydriasis free, with which the protocol could be finished in just several minutes. Here is an example. The left is the one taken with natural pupil, and on the right is taken after pupil dilation. They look very similar, so we conclude that Pupil dilation is optional in Optos. However, when we take a second look to compare the detection rate of the far peripheral lesions, here the granuloma lesion at 8 o'clock, obviously the right one shows more. Thus, in a few of cases, especially the lesion is located far peripheral, mydriasis is of great help. With mydriasis, the far peripheral was seen. Is the imaging of peripheral reliable? Another issue related to ultra-wide field imaging is the distortion or warping that is produced when the curved retinal surface is projected onto a two-dimensional image. The peripheral lesions looked larger, more predominant than the real one. This may affect the quantification and measurement of the lesions in the peripheral. In most adult disease, we consider it as a disadvantage. However, in pediatric retinal disease, I consider it as an advantage to help us to avoid missing the peripheral lesions. Okay, as you know, this is a case of ocular toxocarisis with a very peripheral granuloma. Besides the wide field fundoscopy, we could have red-free photography, fluorescent angiography, fundus autofluorescence by Optos. With oral fluorescent angiography, the non-perfusion area and the dilated capillaries were well shown. I would like to share with you several pediatric cases. Case 1. Here is the Optos photos in both eyes of one patient. It is unremarkable. Yeah, right, unremarkable. The photo is clear. The field is wide. So it is a good picture with high quality. Remember, this is a picture taken from a baby who is only 4 weeks old, and the baby is awake. No anesthesia was performed. How to position the unit in front of the Optos? Here is the working picture. It is really a teamwork. The baby was held from the back with flying baby position by one technician, and the second technician was able to open the eyelid. Was able to open the eyelid and capture. And with Optos, ROP screen is easier than before. This is an Optos imaging from an ROP baby whose corrected gestational age 36 weeks only. Case 2. This is a 5-year-old boy with best corrected vision acuity of 0.4. He is with no symptoms and is found with low vision during the kindergarten registration tests. As you can see, there are a large avascular area in the peripheral and a V sign located at the temporal side. The wide field FFA showed the lesion even more clear, highlighted the avascular area as a white star, increased retinal vessels, temporal dragging of the macula, and abnormal vascular leakage. Case 3 is a representative Coats disease. The subretinal exudate was seen in the macular area, and the vessels dilated a lot at the temporal peripheral. With wide field FFA, the details of the peripheral vessels were shown better. Case 4 is a 3-year-old child with decreased vision in his left eye. FFA showed a macular CNV lesion in his left eye. OCT confirmed the presence of CNV with only low activity. The OCT in the right eye demonstrated the presence of previtaliform lesions characterized by a thicker layer between RPE and the ellipsoid zone. This boy is diagnosed as Best disease, in which finally confirmed by the genetic test. Furthermore, Optos is not perfect. We still are calling for some modifications for children, such as attention-grabbing targets, enhanced imaging stitching, and video recording should be concerned in the future machine. As a conclusion, with Optos ultra-wide field fundus photography and fluorescent angiography, it permits good visualization of the pan-retina, especially the nasal and the temporal, and it is of great help to find the peripheral lesions, especially in children with low cooperation. It could be used to capture angiographic images in children 3 years old without any sedation. And finally, ultra-wide FA-guided targeted laser photocalculation could be concerned in the treatment of the pediatric retinal disease precisely. Thank you for listening.
Thank you. Welcome back, everybody. Thank you, Dr. Ding, for that very, very clear and succinct presentation. I think the imaging is very, very impressive. First up, we have a polling question for the audience, and we would like to find out from the audience what kind of imaging device they usually use for infants. And there are a few options from ophthalmoscopy to contact cameras or an Optos, and we'd like to know what the audience is using. While we wait for their response, Dr. Ding, can I ask you, are there any tips or tricks you'd like to let the audience know about how you manage to get those good images in infants on your Optos? Is it some particular thing you use to distract the baby, or some particular position that you feel is best? Or do you actually give some sedation, or is this all without sedation? Because I think that's very impressive for a baby photo.
So baby photo, okay. So it is without anesthesia. We just use the flying baby because, you know, the newborns, they are so tiny. So I don't think the anesthesia will be safe. So we just try do it without any anesthesia. So the flying baby position, we call it flying baby position, is good for the Optos. Try it, you can make it.
Thanks. I think we have tried it, but I don't think we consistently get that much success. So I think looking at the polling question, it seems that most of the audience still use indirect ophthalmoscopy and contact imaging. And I think looking at what we can get from your presentation, I think a lot of people who have that available will be trying the flying baby position as well. Yeah.
Thank you.
Let's go on. Any other advice you would like to give with regards to fluorescein angiography? Do you do a lot of oral fluorescein, or is it always intravenous for your patients?
Yeah, right. So for the fluorescein angiography, we use the RACAM 3 and we use the Optos. So if the baby is small, is too small to resist to examination, that it should be about smaller than six months old, then we use a RACAM. And if it is older than 3 years old, we use Optos. So, but if the baby is between 6 months old to 3 years old, we should use the anesthesia. So I call them the baby from 6 years old to 3 years old. That's the trouble age. So you know, they are too big for for the RECAM, but they are too small for the Optos.
Yeah, I think those are always challenging, and you can't wrap them up either, so you need to get the anesthetist in. Okay, I think we are pushed. The organizers want us to keep time because we have to keep time. So we'll go on to the last presentation, and that's from myself, and I'll be speaking on the management of pediatric retinal diseases, looking at how diagnostic imaging translates into management. I thank the organizers for this opportunity to speak on the management of RP and pediatric retinal diseases. Ultra-wide-field imaging has been critical to the management of pediatric retinal diseases. With ROP in the late 90s, there was development of contact wide-angle retinal imaging devices, which found that image-based diagnosis was superior to ophthalmoscopy and allows for carefully follow-up and scrutiny in response to treatment. It also allowed for a more consistent definition of plus disease, and there have been many groups developing computer-aided interpretation of plus disease, which may be more predictive of progression of ROP. This was subsequently followed by the non-contact ultra-wide-field SLO imaging systems, which can do non-myodratic imaging up to 200 degrees and can be useful in children, although in babies, you need to position them in a flying baby position in order to get the imaging, which sometimes can be challenging. Besides providing photo documentation for diagnosis and follow-up, SLO-based ultra-wide-field imaging is also useful in small pupils and uncooperative patients. Wide-field fundus fluorescein angiography has become critical for diagnosis, for determination of the area of ischemia for treatment, and for follow-up for recurrence or reactivation of disease. ROP is graded into stages and zones, which help determine the treatment algorithm. The recent third edition of the International Classification of ROP provides better definition for plus disease, as well as describes regression and reactivation that can be well known to occur in the era of anti-VEGF treatment. Treatment of ROP is mainly either with laser or anti-VEGF. Evidence of laser is provided in a cryo-ROP and ET-ROP trial. In the ET-ROP trial, they showed that in type 1 ROP eyes, laser provided favorable structural and visual outcomes. This is an example of premature twins born in 2005. Both developed straight 3 ROP zone 2 with plus, and both received bilateral ROP laser with good response. Fast forward 16 years later, although laser was successful at the treatment of ROP, there were suboptimal visual outcomes in the images alone. The first twin had poor vision in the right eye due to macular dragging, with both eyes being highly myopic. In the twin with pictures below, the left eye had amblyopia and exotropia, with high myopia as well as cicatricial and disc dragging changes. Good evidence for the benefit of anti-VEGF therapy in ROP was provided by the BEAT-ROP trial. This evaluated bevacizumab versus laser in type 1 ROP, and they looked at whether ROP recurred by 54 weeks, which they found to be lower in the bevacizumab arm compared to the laser arm. And this was significant mainly for zone 1 ROP, but not for zone 2. And the timing of recurrences for which treatment was needed was much later with bevacizumab compared with laser. Although not statistically significant, zone 2 still had less recurrences than zone 1, and looking at structural outcomes, zone 1 had much better structural outcomes with bevacizumab compared with laser, with 13 eyes requiring vitrectomy for zone 1 only in the laser arm, and even in zone 2, there were better structural outcomes overall with bevacizumab compared to laser. The Rainbow study compared 2 doses of ranibizumab with laser for the treatment of ROP. Here, instead of recurrence, they look at the percentage of participants with absence of active ROP and unfavorable structural outcomes in both eyes at 24 weeks post-injection. The ranibizumab arms had treatment success of 80 and 75% compared to 66% with laser. Although overall ranibizumab had higher success rate, when you compare the odds ratio of success for treatment with ranibizumab 0.2 alone with laser, the odds ratio of 2.2 was barely missed statistical significance with a p-value of 0.051. They also demonstrated that serum VEGF levels were consistent and no different from laser compared with the ranibizumab arms. The study concluded that treatment success of 80% was achieved with ranibizumab 0.2 compared with 66% with laser, and these infants were twice as likely to achieve treatment success compared to laser, and ranibizumab was well tolerated in patients with RP with good safety profile. A recent meta-analysis of anti-VEGF versus laser found that both had similar regression rates, but anti-VEGF associated with a higher likelihood of requiring additional treatment and a longer time to recurrence. However, eyes receiving anti-VEGF required less surgical intervention and had lower astigmatism, whereas laser eyes had a lower proportion of ametropia at the end of the follow-up. Anti-VEGF may have long-term consequences on retinal vascularization. In eyes treated with anti-VEGF, only 50 to 70% achieve complete vascularizations, with vascular leakage persistent in up to 40%. This is consistent with the findings that these eyes have a risk of late retinal detachment. Therefore, follow-up is required to at least 60 weeks, and if there's no complete retinal vascularization, then there is the need for angiography, keep in view laser at this point of time. So in my own practice, I prefer anti-VEGF for zone 1 and posterior zone 2 ROP. I prefer ranibizumab for the less systemic effects on serum VEGF levels, and I believe anti-VEGF gives us a better overall treatment success and structural outcomes when used as primary therapy. There are late recurrences, so we require longer follow-up, and a not insignificant proportion may require laser for persistent avascular retina later on in the follow-up. This is a baby with stage 3 plus ROP, if you look at the posterior notch in zone 1, and the baby received anti-VEGF injections in both eyes. Within a week, there was a reduction in the plus as well as the stage 3, and within 4 weeks, there was no plus and no active ROP present. The baby took a full 78 weeks to reach full vascularization, which is a long follow-up required. The second baby, a 26-weeker, developed posterior zone 2 stage 3 plus at 36 weeks. She received bilateral ranibizumab. Subsequently, there was recurrence of stage 3 plus in the right eye and stage 3 without plus in the left eye. Only the right eye was treated with ranibizumab and the ROP settled down. However, there was persistent avascular retina in both eyes at 60 weeks. These are the images on examination under anesthesia where we show the whole ROP line as well as the avascular areas. A fluorescein angiography was also done, which demonstrate the areas of persistent avascular retina as well as active leakage. And in this case, the decision was made to laser the avascular retina. 6 years later, the child had bilateral 6/6 or 20/20 vision. As you can see, there's a fairly normal anatomical appearance of the macula. Although there's this old ROP changes and some laser in the far periphery, the retina is generally much more normal than the previous child I showed you with extensive posterior laser performed. However, success of treatment with laser or anti-VEGF is not guaranteed, and there will still be eyes which progress to stage 4 ROP and retinal detachment, whether they have anti-VEGF treatment or laser. This baby had ROP stage 3 plus in anterior zone 2 that was treated with laser. There was persistent fibrovascular neovascularization in the temporal regions of both eyes. This was treated with rescue anti-VEGF therapy. In the left eye, the neovascularization settled down. However, the right eye progressed to stage 4A ROP after treatment. This required surgery with a lens-sparing vitrectomy. I prefer to open the conjunctiva, and I put my ports about 0.5 millimeter behind the limbus in the pars pliccata. If vitrectomy is performed, you are not always able to achieve PVD, but the goal is to remove as much of the vitreoretinal traction at the raised ridge and the detached area as possible. I like to use triamcinolone to assist the removal of all the vitreous. And at the end of the surgery, once all the traction is removed, we do some additional laser, and I do a fluid air exchange and suture the wounds. Rarely, you may be presented with stage 5 ROP. This is generally referred from regions which do not have good screening programs. The prognosis is very poor, and in bilateral cases, you may consider surgical intervention in order to preserve some vision in the better eye. In this case, a lensectomy was performed, and we gradually opened up the funnel with both a scissors and a retractor. You have to be very, very, very careful not to create any iatrogenic breaks, because often once you do, you will not be able to successfully reattach the retina. Once as much traction is relieved as possible, the retina will still be detached because this is a non-rhegmatogenous tractional pathology, but as long as you relieve the traction, you can then just close up your wounds and wait for the tractional retinal detachment to resolve by itself, which you can if you have relieved adequate amount of traction. In this baby at 1 month post-op, you can see the posterior pole looks like it's flattened down. There's still some detached area of peripheral traction, but I think this patient managed to regain at least some hand movement kind of light perception vision in this eye versus the other eye, which was NPL. In conclusion, in the management of ROP, the new international classification better reflects variations of severity and response to treatment. Laser is an important management option, but anti-VEGF may have higher treatment success, better structural outcomes, less surgical intervention, and less myopia, especially for posterior disease. But the use of anti-VEGF must be balanced by the risk of recurrences that may occur later and requires a higher follow-up burden, which is not possible, and screening remains critical for the prevention of blindness in ROP. I will next go on to cover the management of some retinal vascular diseases that may mimic ROP. The first is familial exudative vitreoretinopathy, which is a hereditary ocular disorder characterized by abnormal peripheral retinal vascularization in at least one eye. In babies with no history of prematurity or disease tempo not consistent with ROP, and there will be variable degrees of retinal traction, exudation, neovascularization that can occur at any age. They're usually associated with mutations in the Wnt signaling pathway. It's familial, but expressivity may be asymmetrical and highly variable, and positive family history is only present in about 20 to 40%, and inheritance can be dominant, recessive, or X-linked. This is the staging of FAVR. In stage 1 avascular retina, you can perform regular follow-up and consider laser photocoagulation. Once there's neovascularization, you need to photocoagulate the avascular areas, and surgical interventions required with retinal detachment. Intravitreal anti-VEGF agents have also been used to provide temporary regression of neovascularization or exudates, although they tend to be recurrent, so ablative therapy like laser is still required. This is a 14-year-old girl who presented with poor vision in the left eye that was found with FEVR with tractional retinal detachment. Fundus fluorescein angiography demonstrated the abnormal vasculature and extreme peripheral non-perfusion. This was associated with a tractional and exudative retinal detachment, which required surgery. In the better eye, non-perfusion was also seen, and this was treated with laser photocoagulation. Due to the severity of the tractional exudative retinal detachment, a decision was made to perform combined scleral buckle and vitrectomy. I like to use TA again to highlight and stain the vitreous to ensure you have complete removal of the posterior hyaloid. In order to remove all the tractional bands, I may do bimanual surgery with both a cutter and the scissors or forceps, and subsequently you perform laser photocoagulation, flatten the retina, and in this case there was a small iatrogenic break, and therefore oil tamponade was used at the end of surgery. This is the eye a couple months later. As you can see, the tractional retinal detachment has been resolved, and there was improvement of vision from light perception to counting fingers of about 1 meter. In FEVR being familial, it's important to look at family history. This was a non-consanguineous family. There were 2 children, and this was the picture of the girl's younger brother who was asymptomatic and was 6'6" bilaterally. But on fluorescein fundus angiography, you can denote actually quite extensive areas of retinal non-perfusion, and retinal laser was performed to these ischemic areas to prevent long-term complications. So FEVR can both present in older children as well as infants. This is a 5-month-old Chinese female with full-term normal delivery who was noted a few months after birth to have a right convergent squint. On examination of right eye, there was a severe retinal fold with basically a very dysplastic-looking macula. There was extensive areas of avascular retina in the periphery, and in the left eye, there was also extensive areas of avascular retina and a developing macular fold, although the macula had not detached like the right eye. So we then sent the baby for a fluorescein fundus angiography, and in the angiography, you can see there are areas of peripheral non-perfusion, abnormal retinal vessels, as well as leakage in this better left eye. In the eye of more severe, almost a detached retinal fold, there were areas of peripheral non-perfusion, as well as late retinal leakage, and this was lasered to prevent any progression, worsening neovascularization, or hemorrhage. In the better seeing left eye, the decision was made to perform a vitrectomy to prevent progression of the tractional retinal fold and preserve vision in the better eye. This is my technique, the similar insertion of the cannulas. Again, try to perform a vitrectomy to relieve as much traction that's usually along the edge of the vascular and the avascular retina. I like to use TA again to stain to make sure you can remove as much vitreous as possible. And subsequently, after shaving down as much of the traction, I stain with membrane blue that allows me to remove any remaining tractional membranes. And I also like to use the flex loop device to try and relieve any remnant fibrotic material and try to basically sweep open the tractional retinal fold. And the end of surgery, laser was performed to the avascular retina, and the eye was just left with an air tamponade. These are the images 1 month post-op, and you see the macula is kind of opening up, the fold is reducing, there's laser, there's less vascular changes and tortuosity. And if you compare the pre and post-op different photos, you can see a big difference in the severity of the macular dragging and fold. And if we had not done this, I believe this fold would have continued to progress and would have resulted in this eye having poor vision much later in life. The last retinal vascular pediatric disease I'll quickly cover is Coates disease. This is known as a telangiectatic aneurysmal retinal vascular disease with extensive exudation. Again, part of a wide spectrum of retinal vascular diseases. Males are 3 times more likely than females to be affected with no racial ethnic predisposition, and it's unilateral in 80 to 95% of cases, presenting poor vision, strabismus, leukocoria, pain, cataract, and neovascularization. On angiography, you'll see abnormalities of the retinal vasculature with peripheral non-perfusion. There tends to be pronounced telangiectasia and aneurysmal changes and beading of the vessel walls with leakage in areas of capillary non-perfusion. Again, with the prior conditions, management is determined by the staging that looks at the severity of disease. Where exudation has occurred significantly, fluorescein fundus angiography guided ablation therapy, either with laser or cryotherapy, targeted at the leaking vessels and areas of non-perfusion can be very effective. There are cases where you need to use intravitreal anti-VEGF or steroids to temporarily reduce the edema or exudation that can help improve outcomes or help you perform laser. Surgery is required for retinal detachment. This is largely for tractional or secondary ragnotogenous detachments, but this can also be required in these maculative exudative RDs where you can't perform cryo laser, where you may need to drain the subretinal fluid in order to be enabled to perform the ablative therapy to stop the exudation. This 3-year-old boy presents with aqueous squid noted by the parents, slight decreased vision in the right eye, although on the toptic examination he was noted to be actually straight with a pseudo squid, but dilated fundus examination noted this. The boy is only 3 years old, not very cooperative. This was an unsedated examination, and you can see wide-angle SLO imaging can be very effective even in these cases, and you will see later it becomes even more effective once the kid gets more and more comfortable putting their face in front of the machine. Since we didn't think he can cooperate with a full angiography in front of the Optos machine, we sent the patient for an examination under anesthesia. These are the peripheral contact wide field imaging pictures that shows the extensive telangiectasia, aneurysmal dilations, and exudates. And on angiography, you can identify the vascular abnormalities, delineate the area of non-perfusion, as well as target the aneurysmal changes as well as leaking vessels in order to reduce the leakage in this disease. So the baby had laser photocoagulation performed, and once he got comfortable with the Optos, he was able to do serial images. And as you look at these images, you see the amount of hard exudates is pretty extensive. This is only a month after treatment. This is another 3 to 4 months later, slightly less exudates. And in the most recent images, the exudates have far decreased compared to the original images, and a picture of his normal left eye. So in conclusion, wide-angle imaging with angiography really, I think it's critical in the management of retinopathy of prematurity and other pediatric retinal vascular diseases. The treatment for these diseases is often a combination of anti-VEGF and ablative therapy with angiographic guidance, and surgery will be indicated in retinal detachments, and early surgical intervention when indicated can provide good results. I thank you very much for your attention. Okay, welcome back everybody to our last panel discussion before we end this seminar. And I think we'll bring up the last polling question, which is actually kind of a key question an audience member brought up as well. So what's the primary treatment choice for ROP for yourself in this day and age where we have all these options available from laser to anti-VEGF? And I suppose some people may still consider cryotherapy if they don't have access to the other modalities. While we wait for the audience to answer, could I ask Dr. Zhang Guoming first? You have had a vast number of experience with all these cases that you've treated. And I think you've really seen the transition from cryo in those old days to laser to now anti-VEGF. What would you say is your primary treatment choice for ROP type 1 pre-threshold disease in today's age? I think unfortunately we may have lost the audio connection from Dr. Zhang. While he tries to get that up, Dr. Ding, yourself?
Yeah. So in my clinical practice, I prefer use anti-VEGF in majority of the cases. And then after anti-VEGF therapy, if the vessel is still very dilated, a lot of plus, then I do laser. But I think only about 10% of the children need lasers. Anti-VEGF will be okay. So monotherapy anti-VEGF will be okay in 90% of the patients.
Dr. Zhang, did you manage to get your audio working? What is your preference for primary therapy?
Okay, thank you. I'm sorry. I approve your opinion for ROP treatment. In China, some doctors choose anti-VEGF treatment instead of laser treatment. But in my group, in my hospital, I choose laser treatment for anterior ROP case and just anti-VEGF treatment for posterior zone 1 or post zone 2 ROP or AROP. Maybe when it's recurrent, I will choose laser treatment. That's my opinion. How about you, Dr. Tan?
Yeah, I think I would say we will be on the conservative side now, but I am kind of edging even some of the anterior cases if they are very, very aggressive looking with very high stage 3. I do think they do benefit from anti-VEGF because those are the cases that we found when we treat with laser first, they don't respond as well. And then we end up with rescue anti-VEGF later. But I do kind of agree in some of these cases, when it's very anterior, you may want to just use laser because it may save you that kind of unfortunately painful long-term follow-up that the anti-VEGF cases do end up with. Do you all, maybe Dr. Ting first, do you all do FFAs for these anti-VEGF cases at a certain time, or you follow up clinically until you're satisfied with vascularization?
Okay, so to me, I don't do the FFA before the treatment, but will do it during the follow-up.
Dr. Zhang, do you tend to rely on FA in any part of the management or follow-up?
When after anti-VEGF treatment, when the case occur, I will choose FA, then choose anti-VEGF treatment again or laser treatment.
Is there anything that drives that decision? Is it again the position, whether it's anterior or posterior? Of whether you choose anti-VEGF or laser for repeat treatment?
When the case repeated or recurrent, I will say the disease zone 1 or post posterior zone 2. When the disease located zone 1 or posterior zone 2, I always use anti-VEGF treatment. But when the disease located anterior zone 2, I will choose laser treatment.
Okay, so very good tips there. So I think maybe we have that last question from the audience. Maybe Dr. Ting, do you think there are any cases of ROP where anti-VEGF is contraindicated?
Yes. Okay, so where is the question?
The question was, are there any cases of ROP where anti-VEGF is contraindicated, where you would never use anti-VEGF? Or you feel most cases may benefit still from anti-VEGF?
So so for the most cases of the zone 2, zone 3, anti-VEGF is good, but if the RP goes to the stage 3 and 4, there is some retinal detachment, and then no anti-VEGF, because anti-VEGF will progress them, so will make the RP worse.
And I think that there was one more question again on the flying baby position, if either of you would like to give any more tips.
Yeah.
I'm interested. I think what they're referring to is how do you handle the baby? In our practice, we tend to get 2 people to hold the baby. I've seen before where some setups, they actually have a nice raisable table, which they can put the baby on that kind of slots right at the right level for the machine. And I'm trying to figure out how we can get one of those for my own setup. I don't know about what you use.
Okay, actually, we do have that kind of table. So we also have applying for a patent. But actually, in my daily practice, just use the hands to hold the baby. That is the best way, because the baby is too small. Just use one hand to hold it. That will be okay. Yeah. Dr. Tan, I have another question about the fever. So can we discuss it a little bit more?
Sure, maybe one last question before we run out of time.
So because you mentioned the family history is positive in about 20 to 40% of the families. So in your practice, do you use the Optos to screen both of the parents if the diagnosis is possible fever?
I think when we think it's fever, we'll try to get a whole family, and we would both do an Optos imaging as well as an indirect ophthalmoscopy. And often if they're younger siblings, I think it's worth doing an angiogram, because sometimes there are changes you won't pick up. And usually it's the younger siblings where you would want to put an intervention to prevent them to have vision loss later in life. If the parents are 60 years old already, it's not so likely that they will develop complications, obviously, by that time and age. Okay, great. Thank you very much. Sorry, yes.
So even after the examination, the positive rate is just 20%, because it is not consistent with my practice. So after the
I think if you do FA, it's probably closer to 40% to 50%. Yeah. Yeah. I think the lower numbers is because people just examine casually on the ophthalmoscope, and you will miss those changes. So you're right in that aspect.
The positive rate is about 90% in my.
Okay. We find I think we have about half. I don't know, Dr. Zhang, do you find it's much stronger than that? And do you do genetic testing for all these babies or these children with fever?
Yes, and the positive rate is about 65%. So much higher than the literature told us.
Sorry. In my team, older more 1 year, I will choose EUA, examination and anesthesia. Before 1 year, I will examine just topic anesthesia.
Okay, thank you very much. I think we've run out of time. Thank you, Dr. Ding and Dr. Zhang. for the great discussion and talks today. And again, as well, thank you very much to Nikon and Optos for hosting this webinar. Before the audience logs off, we would very, very much appreciate if you answer the survey that's going to pop up right after we close the seminar. That would give Optos and Nikon the feedback they can to help them plan future seminars and make this experience better for everybody. And again, thank you very, very much for my two speakers here with me today. Thank you again for the audience, and I hope you have a great evening tonight. Good night. Bye-bye.
Bye. Bye-bye.
In less than half a second, in the time it takes a camera to capture an image, you capture the most important moments of your life. In less than half a second, as fast as an eye blink, you could capture the most important moments of your patient's eye health. In less than half a second, you can get the whole picture. The OptiMap technology images the retina faster and with a wider field of view than ever. OptiMap technology produces images that reveal more pathology, helping you find disease sooner and treat it more effectively. Less than half a second can help you prevent vision loss in your patients, so those important moments never fade from view. Less than half a second, and this proven tool helps you uncover critical information to make more effective clinical decisions, as shown in over 400 peer-reviewed studies. Less than half a second, and you will see the value of OptiMap imaging and diagnosis, treatment planning, and patient engagement. Less than half a second can increase your practice economics. Faster retinal imaging frees you to do more patient-critical activity. The most important moments of your life can be captured in less than half a second. That includes an OptiMap image.